give a big thanks and an introduction and welcome to, first off, T. Abraham. T is the Regional Vice President of North Bay, Northern Sierra, and Redwood Coast Hospital Council of Northern and Central California. Welcome, T. Peggy Wheeler is the Vice President of Rural Healthcare and Governance Division of the California Hospital Association. Welcome, Peggy.
Thank you.
And Mimi Hall is the Director of Plumas County Public Health Agency. So thank our panelists for being here. And I'm, without further ado, going to go ahead and get started and leave you all to it.
All right. I'm going to do a bunch of the speaking. Peggy and I have talked. She's going to interrupt me frequently, okay, so that we can mix it up a little bit. I've got, I don't know how many, 20, 30 slides here that we'll go through. And I might go a little bit fast. My hope is that there'll be a lot of dialogue, and so I'll go through it kind of quick, and if I get too quick, just stop me and go from there. So with that, and click, please. So it was very nice enough to introduce us, but I thought, you know, who the heck are these people? What do we do? Why are we here? Okay, so as far as who we are, I'm with the Hospital Council of Northern and Central California. We're a regional association of hospitals. Hospitals are members of our association. And your 3 local hospitals are all members of the association. There are regional associations like ours. We all work together to cover the entire state, almost 400 hospitals in the state of California. I serve 45 hospitals in 18 counties from about the Golden Gate Bridge to the Oregon border. And what do I do? So I help bring hospitals together on certain issues. I help with educating hospitals and advocating for hospitals. We get involved in a lot of local initiatives. There was, for instance, just in this county, the local LAFCO, there was an issue related to the hospitals, and both Peggy and I came up and offered our perspective on that. That's the kind of stuff we do. And Peggy, as far as you might want to talk about what you do with CHA.
Sure. Thanks, T. So my role at the Hospital Association is to do advocacy and representation on behalf of all the rural hospitals in California. There are 60 plus small and rural hospitals in California, 34 of which are the smallest hospitals. They're called critical access. That's a federal designation. It has rules that go with it. The hospital here in Quincy is a critical access hospital. My role primarily occurs in the state capitol. As bills are introduced at the state capitol and they impact hospitals, my voice should be how they impact rural, because sometimes a bigger hospital can do what's being proposed in legislation, but a small hospital would really struggle with that. So I bring sort of that rural voice to what happens in Sacramento.
All right, and then while we're here, we were invited here, so hopefully that won't be a mistake. But anyway, and then I wanted to throw this in just for the heck of it, and that is a drawing of Switzerland. And I wanted to do that because you can't talk about healthcare today without getting into politics. And our organizations, the two, Peggy's with California Hospital Association, I'm with the Hospital Council, we are Switzerland. Red comes, red goes. Blue comes, blue goes. Ideas come, ideas go over the political spectrum. In hospital associations, we don't have the luxury of taking on to one political party or one point of view, because hospitals have to be there when the party's in favor, when the party's out of favor. And so our organizations do a real good job of navigating everybody. And the safe ground for us is facts and truth. And so what you're going to see up here tonight is data-driven, fact-driven, and if it looks partisan to you, that will be your judgment, because we're not here to push red or blue or anything like that, but we're going down that path because you just can't talk about healthcare today and tomorrow without getting into that. And I'm neutral. I spent a week in Washington, D.C. last week. I bought my founding father's signatory tie. So all the founding fathers signed my tie. So anyway, and then, so what we plan to talk about today is healthcare today, healthcare tomorrow. I think you're going to be thoroughly depressed with those two, so I felt obligated to throw in some good news. And then when you feel like the whole thing's out of control, I want you to know that it's well within your control, and that's our solid gold recommendation, and then hopefully Q&A. So, healthcare today. If you're a fan of Talking Heads and David Byrne, which I am, same as it ever was. Healthcare is incredibly complicated, incredibly political, and highly...
Who knew how complicated it was?
Yeah, okay. Don't go there. No, and it's really highly regulated. Both Sacramento and Washington, D.C. are very involved, and the things they do come right into this town, right at the hospital's doorstep on a daily basis in ways that you don't even want to know. This time around, that's been true for a long time. It will be true for a long time. Now even more than ever. I mean, unless you're asleep or don't read a newspaper or watch TV, you have to know that healthcare is in the news big time. And with Sacramento, as far as what's going on, there was this year alone, since January, there's been a record number of bills introduced, more than ever has been introduced in a year. I think it was 2,500, I think?
2,500.
2,500 bills. 2,500 bills. And we have full-time lobbyists that do nothing but monitor the Capitol, because there are so many people that have never been involved in healthcare, that aren't physicians, that were never nurses or anything, that sit in DC and Sacramento that think they know how to run a hospital better than Jeff does, Dr. Keppel does. And they're not shy about talking about how he should run his hospital and coming up with laws for that. I don't know if you wanted to talk to that.
The only thing I'll say about that is that a lot of legislation is media driven. So if something happens, a bad outcome, and those are unfortunate things that happen, a constituent will bring that to the legislator and say something needs to be done about this. That's why there's so many bills. In fact, I'm glad that there's only 2,500 bills. Because if you think about it, everybody has the best idea for how to make healthcare smoother, better. So I'm glad we only have 2,500.
Yeah, and a lot of them had either direct or indirect impacts to healthcare. So a lot of them didn't, but a lot of them did. So.
The other thing, and thank you for saying I interrupt often.
Right. That's it. Not that Dr.
He does know me well. The other thing that helps in awareness here is that there's a California Hospital Association, there's a California Nurses Association, there's a California Medical Association, there are California Associations of Health Plans. So all of these interest groups have particular things they're interested in. So the way bills work, and I won't do too much of the how bill becomes a law, although I like that conversation, is that the Hospital Association will sponsor bills that are good for hospitals. So we have a certain number of bills that we're trying to advocate for, but we do very few of those because every year there are so many bills you have to fight. So we have a lot of bills that we're opposed to, and then a lot of bills that we have to follow to make sure that they don't turn into bills that you need to oppose. So we have very few sponsored bills, things that we're responsible for, but a lot of bills that we need to oppose.
And we also do ballot measures. So if you voted for yes on 52, which passed, we sponsored that. That was to protect hospitals in California. If you voted yes, thank you. If you voted no, shame on you. But it does a lot to protect hospitals. And so there's actually ballot measures that we'll put on each year. So as far as issues that are going on in the state, I am going to drill down to local level here. But I just want to let you know overall, California is really unusual. And I'll get into that more, but some of the big issues is we have an incredibly large Medi-Cal population. And I don't know what you think Medi-Cal means, but it's a lot of children, a lot of elderly, and a lot of working poor. We have incredibly low Medi-Cal reimbursement. Our state reimburses hospitals and physicians we're in the bottom 5, I want to say maybe even 2, but I know it's in the bottom 5 of reimbursement. So a physician in California practicing in Beverly Hills would get paid less than a physician in most states and hospitals as well. So you happen to be in a state where your state government does not fund the matching share to the federal piece. You happen to be in a state where your state does not, our state, I lived here my whole life, does not fund Medi-Cal at a very high level. We have, this isn't unusual with California. Medi-Cal is unusual. We're one of the lowest. Mental health, this is an issue across the United States. It's really bad in California. The diagnosis, treatment, the whole system around mental health is broken. I will go off into, I'm taking up my official role here, and I'm going to my personal role. I consider it a national disgrace and a national embarrassment. Now I'll go back onto my official role. Drug abuse is a big issue in the state of California, especially opioids. Homelessness is a great big issue in the state, and workforce shortages. What this is in healthcare, there's an acute shortage all across the state. There's a hospital system in LA that reported they're short 1,500 physicians. And in urban areas and rural areas, there is a shortage of doctors, there's a shortage of nurses, there's a critical shortage of lab personnel in the state. Just about anyone you can think of related to healthcare, there's severe shortages, right, Dr. Kempel, right, shake your head.
May I interrupt again?
Yeah.
So what I want to add to the workforce shortage issue is there continues to be shortage in rural and some near rural areas, but recognize that there is a maldistribution of workforce in California. There are areas near our urban and suburban centers where there's a lot of physicians and nurses. We still continue to suffer from that lack of distribution evenly across all of those. So one of the things that is very good that we were able to achieve last year that went into effect as of January 1 this year is that we're able to get a bill passed that allows critical access hospitals to directly hire physicians. Why that's helpful is because when you're able to recruit physicians to come out and look at your small rural hospital, what they say to you is, I'd be happy to come here, but I need to be hired. And we couldn't do that before, so now we have
what
the
Peggy's
ability.
talking about, you're also in a state, we're also in a state that we're one of the few states that hospitals cannot employ physicians. They may seem like they work at the hospital or work in the clinics, but they're not actually employed. In California, there's these really convoluted and complicated ways that hospitals contract with physicians to have them work in the hospitals and the clinics. And so this was a very important bill that got passed to allow for a small percentage of California hospitals to employ physicians. So you roll up all of these issues, low reimbursement, homelessness, and one of the biggest issues in this state, and this is not unusual, not unique in California, is emergency room overcrowding. We've got a Medi-Cal population that doesn't have a place to go. They go to the emergency room. We've got mental health patients don't have a place to go. They go to the emergency room. Drug abuse. Then because there's these shortages of primary care doctors, I can't get an appointment, so something gets worse than it should. Now I go to the emergency room. So what's happening is all of these gaps in the system and all of these social kind of misses in our society and everything, they're winding up in the emergency rooms of hospitals. And it's a big issue. It's an issue that both Peggy and I's organization is working hard to try and take a swing at it to try and make it better. That's like a whole other half-hour talk I won't get into. There's no place like where we live. We have a ton of people here. We have a very diverse population. We're geographically complex. We have places like this, and then we have places that are like downtown LA. And we have one of the largest economies in the world. We're very different, even within the United States. The good news is California, when it comes to healthcare, we're in very good shape. We've got a real good history of innovation. We can get into that a little bit. Another place we're unusual is 91% of Californians have some form of health coverage. Okay, it's not perfect, it's not ideal. Sometimes there's issues of access, but we have a very high number of people that have health insurance. That's largely due to, well, I'll talk about that later. We have a lot of wealthy in this state, but we also have a lot of poverty. We have the highest level of poverty in the United States. And that may be news to you. The rest of the country is at 16%, we're at 23%, and that's because there's been a new poverty measure that's come out, and it takes into account the cost of living. And so when you take that into account, it changes the numbers dramatically, and it takes a lot of people in California into poverty. And that's when I talk about a large part of those people in California that are on Medi-Cal, that are working poor, that's what we're talking about. We have 14 million residents enrolled in Medi-Cal. To tell you how different that is greater than the population of 45 states. We have more people on Medi-Cal than reside in most states. I mean, so we've got a huge, California is very different in many ways. But fortunately now, California chose to dive in big time on the Affordable Care Act. Some states said, stay away, I don't want any part of it. Other states said, yeah, let me stick a toe in, let me try a little bit. Some states dove into the deep end of the pool with, weights around their ankles. That's California. California went in big time and really adopted the ACA. And that's why the enrollment numbers are way up. So as a result, a lot of people now are getting care and preventative and primary services. And there's also, we're very cost efficient in California. The healthcare system is. This is just a little bit of bragging. California, we're big, like I said, we're big in innovation. We also manage costs very well. We've adopted technology very well. And there's a lot of advances here in California in terms of providing accessible, high-value care. In essence, California is a good steward of healthcare dollars and is working well. The next slide. To give you some idea that just because we're hospital-centric, I happen to have a lot of hospital data. These are measures, these are standard measures on hospitals. California is better than the US average in every category. The next slide. So now let's talk about federal issues a little bit. Once again, unless you've been asleep, the political environment in DC is incredibly partisan. It's very unstable. We used to talk about like, hey, I wonder what will happen next year or what will happen next week. Now we talk about what's going to happen tomorrow and wonder what's going to happen. There's a lot of unpredictability. Once again, hospitals and healthcare has to be there day and night, 24/7, 365. These are like pillars of communities, stable. A lot of what we do is affected by what goes on in DC. This stuff is not good. It is not good for a pillar of society that is trying to be there all the time, and having all this go on in DC is not a good thing for your local healthcare system. The ACA repeal and replace, I think you probably saw the House passed that. It now goes to, well, I'll get into that a little bit. When I talk about federal issues, I was talking mainly about healthcare issues. And I'll skip down to Medicare and Medicaid. There's a lot of reforms taking place. There's a lot of cuts that are being talked about. I'll get into more of the cuts in Medicaid a little bit later. Medicare, a lot of the changes and reforms are really happening on the provider side, so you probably won't see or feel those as much, which is a good thing. Tax reform. Why is tax reform up there when I'm talking about healthcare? The reason why is because healthcare is one of the biggest costs in the federal budget. Guess what? That makes it one of the biggest targets. One of the current administration has big goals around tax reform. And believe me, I pay plenty and I'm all for it. That said, a lot of what they're doing in changes with the AHCA is to reduce the cost of healthcare in the federal budget. So what they're talking about is could have a big impact on healthcare, because they're talking about taking a whole lot of dollars out of healthcare. And I'll talk about that a little bit more. So like I said, it passed the House. The Senate, I just spent a week in DC, and I talked to Republicans, I talked to Democrats, talked to senators, representatives. It seems pretty likely that the Senate's going to start over. It seems likely that a lot of the things that came out in the House bill were just, they will not get enough support to pass the Senate, and it's so far off that the word we're hearing is that the Senate's just going to start over. That they're not even going to look at the AHCA bill. We'll see. Who knows? But that's what our crystal ball is saying. Once again, if you go back to what I said about California and how different we are, especially that we have more people on Medi-Cal than is the population of most states, the fact that they're going to start over, we see that as good news. And the reason why is there's a lot of pieces to it. Like, they're talking about things that affect the exchange, and they're talking about grants for states and all kinds of things like that. Those are all interesting and good, and they have a little bit of an effect in California. But the thing that is the 800 million pound gorilla in the room in that bill is there are significant cuts to Medicaid in it. Okay, well, if you're in a state where, hey, I have a little bit of Medicaid, they're talking about cutting it, okay, whatever. When you have 14 million people on Medicaid and they're talking about playing with Medicaid, it has big ramifications for the state. And the other thing too is, I gotta figure out how to say this just right, but you think like, oh wait, that's just a loss of coverage for like the working poor. That's not how the system works. There's three main buckets of people that are seen in hospitals, pretty much Medi-Cal, Medicare, and then commercial, and then those that don't pay anything, really, like 4 buckets. Forget the ones that don't pay anything. Those 3 buckets, they need to work. I mean, like you have to have enough critical mass and enough people and enough payment to make the whole system work. So for instance, like if all of a sudden you're not making enough money on Medi-Cal, well, all of a sudden that new cardiac surgeon you're planning to get, the numbers don't work because you don't have money from Medi-Cal to support it. So this is not just about those people losing coverage. Whether you have Medi-Cal or not, this is not good for the overall system in California. So key elements that are in the GOP plan, they're, like I said, significant modification of the Medicaid expansion. In essence, what's happening is a lot of people that have Medicaid now would not be able to get it in the future. They're talking about changing Medicaid financing. We can go ahead. They're talking about repealing subsidies, so some of the people that are on the exchange covered California would lose those subsidies, so some of those people couldn't afford coverage. There is some good stuff in it. It expands the availability and use of health savings accounts, which is a good thing. They also talked about innovation grants, where if you have vulnerable patients, that the federal government would grant some money. These are all great, and we could spend hours talking about all that's in the bill. It's a very complicated bill that the media doesn't get into very much, but the big, like I said, big gorilla in the room is what it does to Medicaid. And like I said, if you're in a state like Delaware or Rhode Island, what do I care? California's different. So, next slide. So, what does that mean? Like I said, some of the stuff we've talked about already, 91% of Californians have it now. We ran the numbers. That AHCA bill that was passed by the GOP, we took all the changes that are in it, and we took current data on healthcare, and we ran, this is what the number was. If you run it through the filter of the AHCA, it would reduce funding. The changes in the AHCA would cost California $12 billion a year. Okay, so that's what's got us alarmed and worried, is They talked about repeal and replace, and they did do some repeal, and they did do some replace. But when it came to Medi-Cal or Medicaid, they did the repeal, but they did not do the replace. And like I said, I gotta stop saying this. In some states, no big deal. California, big deal. Next slide. Do you want to talk to this, Peggy?
I don't think the actual numbers are important. I think what this shows is the breadth of the impact of the cuts, because as T has described, California has such a large population of Medi-Cal. Any changes to who's covered or how much gets paid, and kind of what we're not, getting into the details of is the formula between the state and the federal government about Medi-Cal, how much the federal government pays and how much the state pays into the Medicaid program. But what you see is just that the bottom line is that if the cuts were enacted the way they're in the current proposal, it would have a tremendous impact in California. I want to emphasize that although it affects California, it affects, those effects are exacerbated in rural. And they're exacerbated in rural because our rural hospitals are more highly dependent on their payer mix being Medi-Cal and Medicare. We have very few, lower percentage of commercial patients. And so when your payer mix is predominantly government payers and then the government starts to tweak those payments, it's hard to budget. It's hard to figure out what you're going to do next.
Yeah, and when I talked about how complicated the bill was, these are all little pieces that are in the AHCA. They're little pieces that they're talking about changing, and that's the filter that these numbers will run through. This is just the effect on hospitals, and you can see it's not pretty. It gets worse over time. Next slide. So big deal. It affects hospitals a ton. What does that matter so much? Well, hospitals contribute $84 billion in salaries and benefits, another $145 billion in economic output, for a total of $229 billion. In terms of jobs that healthcare directly has and that healthcare creates, it's over $1 million. Over 1 million jobs in California. And in rural areas, hospitals and healthcare rolled up are often not only the largest employer, they're the highest paying employer. And so you start messing with, you saw that slide before where it was just going boom in terms of the red to hospitals. You're playing with the economic vitality of California, and once again, to Peggy's point, it's exacerbated in the rural areas. Okay, so next one. This just is another slide about impact. We talked about $229 billion in economic impact. If the current bill passes, it would reduce an estimated loss of coverage for 3 million Californians, and the impact to hospitals alone would be over $3 billion. This, I thought, okay, great, that's California, what do I care? I'm here in Plumas County, what do I care? This is the same thing, but this is Doug DeMalfa's congressional district. This is just what it would do in your congressional district. In the ACA, Obamacare, whatever you want to call it, 75,000 people gained access to Medi-Cal, and another 25,000 took advantage of the subsidies for covered California. And so we talked about how $12 billion would be lost if the current legislation stays as is. In the Malfa's district alone, that's $275 million in a loss of Medicaid resources in just your congressman's district. Peggy, talk to this.
So I wanted to kind of bring it home, and this is publicly available data that's on a website in Sacramento, the Office of Statewide Health Planning and Development. All hospitals report into OSHPD, it's called, their financial data. And I wanted to really demonstrate for you, let you see what Plumas District Hospital looked like before the ACA and what it looks like after the ACA. So if you just look at the payer mix, what we were talking about, Medi-Cal, Medicare, commercial, indigent. In 2013, we were here. After implementation of the ACA, you can see the increase in Medi-Cal went from 2 million to almost 9 million in revenue, meaning that the bottom line for the hospital is doing much better. This is what is at risk if you start changing how we pay Medi-Cal and Medicare. I have the same figures for the other two hospitals here in, so Eastern Plumas. You know, it's the bottom line that's important. You can see that there's changes all along each line, but the bottom line is each of the hospitals, you can go to Seneca, each of the hospitals is doing better. Some better than others, but they're all doing better, and that means that every one of the hospitals in Plumas County would be at risk if there is a tweaking of the Medi-Cal program.
So as far as healthcare tomorrow, I'll talk about that a little bit, but just one thing, like I said, I was just in DC for a week, and one of the things we heard that was kind of encouraging for me is that the House, you know, healthcare is really complicated, and there's a lot of ways to look at changing the ACA, and they did make a lot of changes that you can argue for or against or whatever, but in point of fact, they did not prioritize Medi-Cal, and as I said so many times in California, that's a big deal. One of the encouraging things we heard back in DC is that the Senate does prioritize Medi-Cal, and that the other thing too is the House, they made their decision without input from the Congressional Budget Office. In other words, normally when you propose a legislation, then the neutral, some will argue that, but theoretically neutral body determines what the impact will be numerically. And the House voted without waiting for those numbers. We've been told that the Senate is going to wait for those numbers. So the significant impacts that we're seeing and the things that can happen, we're being told that the Senate will take into account what's going on with Medi-Cal, which once again is really good news for us here in California, and that they will be more numbers driven than the House. So that's some good news. So healthcare tomorrow. Medical advances, even with all this talk of cuts and all this stuff and everything, they just keep going on, and that's definitely coming. The impact of the AHCA, even if it passes as it is, even with all my doom and gloom about how bad it would be for California, most people are saying that the impact of that would not be felt this year and maybe not even next year. And depending on what they do and how they do it, it could even play out further. But for now, no concerns, and certainly not in the immediate future. The other thing that's happening in healthcare is collaboration is really proving to be a way to break through to make real differences. What's happening is these issues that I talked about, like homelessness and mental health, there's been kind of this collective understanding that these issues, they're bigger than anybody can take, that the feds can't handle it, the state can't handle it. Counties can't handle it, hospitals can't handle it, it's bigger. And so what's happening is there's a whole lot more collaboration going on. A lot of the partners are talking more and working together more than they ever have. And that looks like it's going to continue. There's also a kind of an understanding that as bad as it is, if you think the cavalry's coming over the hill, they're not. And when they do come, they frequently bring bad news. They frequently bring lower reimbursement for care. They frequently bring more regulations. So once again, people are realizing, a lot of communities are realizing they can't rely on the state or the Fed to take care of things, that they've got to rise up and do it themselves. And that's a trend that's continuing. Extreme regulation and challenges, that is going to continue. Luckily, hospitals and other providers are pretty good about blunting that for the public and taking that on. the other thing we're seeing is that the major issues we talked about, that they will improve, but it's going to be county by county. Here in California, the way we're structured, counties have a lot of autonomy in what happens in healthcare, and depending on who your hospital is, depending on who your county leadership is, can have a big impact on what happens in terms of healthcare in your county. So as far as healthcare tomorrow, it's going to be way better in this county and maybe stay the same in that county, maybe go back a little bit in another county. There's going to be 58 different stories to tell. Workforce is going to continue to be an issue and probably get worse. Good news. So I thought I would be thoroughly depressed by now. So I thought I better weave this in. Quality is way up. It is crazy. Hospitals and healthcare providers, not only is the state demanding it, the feds demanding it, hospitals want to do it, and I can tell you, I walk into hospitals, I see behind the curtain, I know what goes on, and there's not much to fear. Quality is so much a part of the fabric of your healthcare delivery system. It's just a neat thing. It just gets better all the time. In fact, our organization's created a whole separate entity that's all they do, and a whole staff of people out of Sacramento helping hospitals advance quality, and they do some really cool stuff. Diagnostic tools are just incredible and getting better all the time. Treatment is advancing all the time. I'm old enough to remember that, you know, if my friend's mom got cancer or something, it was a death sentence. It was scary. Today, cancer is becoming a chronic disease for many people. So that trend is continuing. Another thing that's kind of good news is no one seems to want to talk about Medicare too much. When all this talk about the ACA repeal and the AHCA and everything, for the large part, Medicare is not getting touched a whole lot. So I take that as good news. The other thing is, the other good news for you, for the people in this room, is most healthcare. I mean, you read about it in the paper, and you read about the ACA and, you know, what Sacramento does, and we tell you our sad stories of what's going on with all these crazy laws and everything. The fact of the matter is most healthcare is local, and you're in Plumas County and you're lucky. You got 3 great hospitals. When I talk about collaboration being breakthrough, your hospitals work together, your county works with them. I mean, you're doing stuff like this. I mean, I'm not going tomorrow night to other counties. I serve 45 counties. I've done this a handful of times. I mean, this is evidence of your county is doing the kinds of collaborative work that needs to take place. So I think that's really good news for you all. My solid gold recommendation. So if you feel like DC's way into your world too much, and Sacramento's way into your world too much, and you feel like this is out of control, I know this sounds like mom and apple pie, but the ultimate control of your health and your healthcare costs is in your hands. And it really is. It's prevention, it's regular checkups, it's screenings, diet, exercise. The other big thing is supporting your county, supporting your hospitals, and all of your providers. What does that mean? That means that getting educated like this, it means like there may be a fundraiser that takes place in the community. They need it. They're fighting a tough battle, let me tell you. Finding a way to support your local network because they need it. They need your help. The other thing is help with recruiting. Maybe you know somebody was born here that moved to the Bay Area, and they're a doctor, or they're a nurse, or they're a friend of yours kid that is a doctor or nurse, or somebody somewhere that you know, or somebody that's way into the lifestyle here that's now in Boston or something like that. Your hospital, your other providers, they need help getting people to take care of you. And you all know people, and you all know people that are practicing in other places. Tell them how wonderful it is here. Tell them to come back home. Tell them that your hospital's hiring, you know, and help with that effort. So anyway, those are my hopefully a little bit of uplifting and go from there. So, covered a lot. I know I may look political. I don't mean to be political, but I didn't know if it raised any questions or... Yes?
And the 2,500 bills that have been introduced in the legislature, has single payer ever come up?
Yes, it's up now.
Going to single payer?
It's up now.
It is? In what respect?
It's being considered. It'll be interesting to see. It made the first committee hurdle, I think. It got introduced, it went past, it went through committee, so that's the first hurdle. The governor has come out and openly said there's no chance that it's going to happen, and he's not going to support it. And so, yeah, that has come up. It's currently on the docket right now.
Okay, has he said why he wouldn't support it?
Because California can't afford it, and frankly, I agree with you.
It's a finance issue, and I've been with the association for 12 years, and there's been a single-payer bill every year.
Okay.
Yeah, it can't afford
Didn't
it.
they say 450 billion to implement, and the whole state budget is 120?
Is that just in the state?
Yes.
The state
Yes.
single payer.
Yeah.
Yeah, I'm sorry, upstate of California, yes, they were trying to, Assemblyman, I think, introduced it this year. Yes.
I know you said that Medicare wasn't an issue, but I've heard that AARP is against the new AHCA.
That is correct.
And what is there, I don't know the reason for that, if you could fill me in.
Because in some of the tax packages, they harm the elderly in the way they tax, the way they're going to get the money to finance. So AARP came out when it was introduced the first time, and they've been consistent because it puts too much financial responsibility on the elderly. With fixed
It's
incomes.
another question, and then we can go to Mimi, and then we can open it up for even more questions, because I bet
Okay.
Mimi's going to bring up some stuff that raises questions as well. Yeah.
So I was just curious, as advocates for hospitals, are you also advocates for psychiatric hospitals, or is it just?
Yeah, we are.
Yes, there are members as well. So all the psychiatric hospitals, in fact, the colleague that works in the office next to me is the vice president in charge of behavioral health in the state.
Yep, so I'll turn it over to Mimi, and then we're happy to answer questions later as well.